Hello everyone, I hope you are doing well. In the previous video, I had discussed about continuous IV infusion regime. Today, I will talk about fixed dose, fixed time regime, or third one is optimized dose. In fixed dose or fixed time regime, administration of drug by fixed doses rather than by continuous infusion is often more convenient. However, fixed dose is given at fixed time intervals, such as with multiple IV injection or multiple oral administration, result in time-dependent fluctuation in the circulating level of drug, which contrasts with the smooth ascent of drug concentration observed with the continuous infusion. Now we see how multiple IV injections affect. When a drug is given repeatedly at regular intervals, the plasma concentration increases until a steady state is reached. Because most drugs are given at intervals shorter than 5 half lives and are eliminated exponentially with time, some drugs from the first dose remain in the body at the time that the second dose is administered. Some from the second dose remains at the time that the third dose is given, and so forth. Therefore, the drug accumulates until within the dosing interval, the rate of drug loss exactly balances the rate of drug administration. That is, until a steady state is achieved. Now we see the effect of dosing frequency. The plasma concentration of a drug oscillates about a mean. Using smaller doses at shorter interval reduces the amplitude of swings in drug concentration. However, the steady state concentration of the drug and the rate at which the steady state is approached are not affected by the frequency of dosing. Now I move towards what happens when multiple oral administrations are used. Most drugs that are administered on an outpatient basis are taken orally on a fixed dose or fixed time interval regime, such as a specific dose taken 1, 2, or 3 times daily. In contrast to IV injection, orally administered drugs may be absorbed slowly, and the plasma concentration of the drug is influenced by both the rate of absorption and the rate of drug elimination. Here it's a graphical representation of fixed dose. As we can see, a single dose of drug given orally results in a single peak in plasma concentration, followed by a continuous decline in the drug level. Now we move towards the optimization of dose, which is divided into three segments, that is maintenance of dose, loading dose, and the dose adjustment. Right? One by one, I will discuss in detail what happen, why we do optimization. The goal of therapy with a given drug is to achieve and maintain concentrations within a therapeutic response window while minimizing toxicity or side effects. With careful titration, most drugs can achieve this goal if the therapeutic window of the drug is small, like digoxin, warfarin, and cyclosporine. A plasma concentration range within which therapy is effective will be defined. The dosage required to maintain therapy will be computed and administered as a maintenance dose or a loading dose, right? And drug concentrations are subsequently measured. The dosage and dosage frequency can then be adjusted if not within the therapeutic range. Now we move towards the maintenance of dose. Drugs are generally administered to maintain a steady state concentration within therapeutic window. To achieve a given concentration, the rate of administration and the rate of elimination of a drug are important. It takes 4 to 5 half lives of a drug to achieve steady state systemic concentration. Dosing rate can be determined by knowing the target concentration in plasma clearance of the drug from the systemic circulation and the fraction absorbed, that is bioavailability, denoted by F. Now we have formula, that is dosing rate is equal to target plasma concentration and clearance divided by bio, bioavailability, right? Now we move towards the loading dose. A delay in achieving a desired plasma level of the drug can be clinically unacceptable. Therefore, a loading dose of a drug can be injected as a single dose to achieve the desired plasma level rapidly. followed by an infusion to maintain the steady state. In general, the loading dose can be calculated as loading dose is equal to volume of distribution into desired steady state plasma concentration divided by bioavailability. For IV infusion, the bioavailability is 100%, and the equation becomes loading dose is equal to VD desired steady state plasma concentration. Loading dose can be given as a single dose or a series of doses. Loading dose are given if the time required to achieve half-life is relatively longer and the therapeutic benefit of the drug is required immediately. And disadvantages to the use of loading dose include increased risk of drug toxicity and a longer time for a concentration of the drug to fall if excess drug level occurs. A loading dose is most useful for drugs that are eliminated from the body relatively slowly. Such drugs require only a low maintenance dose in order to keep the amount of the drug in the body at a therapeutic concentration. However, without an initial higher dose, it would take a long time for the amount of the drug in the body to reach a therapeutic value that corresponds to a steady state level. Now we move towards the graphical representation. It determines the accumulation of drug administered orally without a loading dose and with a single oral loading dose administered at time t. Now we move toward the dose adjustment, where the pharmacokinetic principles used to optimize therapy for a given individual or a patient population while minimizing side effects or toxicities. Monitoring the drug and correlating it with the therapeutic benefits provides an other tool to individualize therapy. VD is useful. VD is a volume of distribution is useful because it can be used to calculate the amount of the drug needed to achieve a desired plasma concentration. For example, assume the cardiac output of a heart failure patient is not well controlled due to inadequate plasma level of digoxin. Suppose the concentration of the drug in the plasma is C1 and the desired level, the target concentration of digoxin is C2. A higher concentration, the clinician needs to know how much additional drug should be administered to bring the circulating level of the drug. Here it's a equation. We can see Vd into C1 is equal to amount of the drug initially in the body, and Vd C2 is equal to amount of the drug in the body needed to achieve the desired plasma concentration. The difference between the two values is the additional dosage needed, which equals to Vd into C2 minus C1. Here it's a graphical representation where we can say the plasma concentration during the oral therapy fluctuate around the steady state level obtained with intravenous therapy, and when dosage are doubled, halved, or stopped during steady state administration, the time required to achieve a new steady state level is independent of the route of administration. Here I conclude my topic. For more information, like and subscribe my channel. Thank you.